Hello everybody. Today I'll be speaking on the topic Laryngo Tracheo Bronchial foreign bodies, in which I'll also be presenting a case which we had recently managed using optical grabbing forceps and about the topic. So first, let me take you all to your childhood. We all had heard the stories of Snow White and Seven Dwarfs, in which a piece of apple gets lodged in the throat of the princess and she comes back to life only once prince removes that piece of throat and takes away the princess. I think if prince wouldn't have been a prince, he would have been a very good otolaryngologist. But he was lucky to get a patient who was adult, whereas I was not so lucky when I got a patient just 2 years 9 months old, and he presented with the chief complaint of cough which had been present for past 4 months and reported to the pediatric OPD. Parents also gave history of the child getting tired very easily and decreased growth. A chest x-ray was done which showed a shifting of the heart to the right side with a hyperinflated left. Subsequently, suspecting a foreign body, CT scan of the chest was done and it can be seen this is the carina, and as we are moving to the left bronchus, here a oval shaped translucent foreign body can be seen, which was lying in the left bronchus where it further divided into its branches. So a multidisciplinary approach was taken to this case. Radiology of course helped us with the virtual bronchoscopy to provide the exact location where the foreign body was lying, while anesthesia, ENT as well as pediatric had their own difficulties and challenges which were. The anesthetic difficulties included that the age of the child was less and SpO2 was between 80 to 85. Ventilation of one lung was compromised. Endotracheal tube during any surgery forms the ultimate guarantee for the anesthetist that whatever happens he can manage the case. But in this case, endotracheal tube of course couldn't have been put because the airway was shared by the anesthetist as well as the ENT specialist, and therefore the chances of oxygen desaturation during surgery were high. It further didn't help that there would have been a manipulation of the airway and chances of bleeding in the trachea or the bronchi. As ENT specialist, I had my own challenges that the age group was less, the size of trachea would be even lesser and giving me less room to operate, while a deviated trachea, as could be seen from the x-ray, further increased the difficulties. Right lobe is the one which is most commonly involved, whereas whenever left is involved, it is more difficult to remove the foreign body. Also, a history of 4 months ensured that there might be impaction of the foreign body. And again the shared airway with the limited time, whenever my endoscope would have been in, there would have been no ventilation and giving me just 60 to 90 seconds before the SpO2 had started to fall. Pediatric also was not without challenges. The age of the child was less with the compromised function of one lung. There was high possibility of oxygen desaturation during the surgery because of the shared airway problems, as I told earlier. And also post-operatively there are high chances of pulmonary edema, not only due to manipulation of the airway but also because the bronchial lavage which had to be carried out and the possibility of any residual foreign body particles. Post-op pneumonitis of course couldn't have been ruled. So a team meeting was held and we decided to go on with the case. Parents were counseled, high risk consent was taken, and we started with the surgery. I'll show you a small video of the case which was done. Here as can be seen that there is no endotracheal tube. Ventilating bronchoscope has been put by the anesthetist up to the level of the vocal cords, from where the ENT specialist further took it up to the carina, and as can be seen ventilation is being done through a ventilating bronchoscope at the start of the case. Now here the ENT specialist is putting the endoscope through the ventilating bronchoscope so that he can further take it into the left bronchus, and here the endoscope of the optical grabbing forceps are moving into the left bronchus. We are presently at the level of carina and moving into the left bronchus, and here the foreign body has started to appear. Now it can be seen more clearly. This is a brown chana, small brown chana seed which is there, but the moment we touched the foreign body, the child went into a laryngospasm, and so we had to bring out the instruments. Now again we are going inside for a second attempt, but as can be seen now the problems of edema and fogging of the endoscope had started. So we had to bring out the endoscope again, use good defogging agent with regular suctioning to ensure. This is the third attempt in which already the edema and minimal bleeding has set in, and so it was very difficult to remove the foreign body. But we were able to locate the foreign body. Here the forceps are seen before they are opened to grasp the foreign body. This foreign body can be seen along with the surrounding tissue fluid. Now the forceps have been opened and the foreign body has been grabbed, and now the complete set of the endoscope along with bronchoscope are being taken out of the trachea to ensure that the foreign body comes out completely in one room. It can be seen in our photograph that the foreign body is being brought out. This is the photograph of the foreign body, but we realized that the chana had opened up, and so parts of that white inside, 3 or 4 parts were left inside. So we had to go 3-4 times more inside to remove each and every remaining part of this foreign body, and every time difficulties being increasing. However, we were able to remove this foreign body. This is a complete set of these specialists. Thank you. So later the child was shifted to the ICU to ensure that there was adequate SpO2 monitoring and ventilation of the child. And this is the evening X-ray which showed that the heart had shifted back to the left side, and there was good ventilation of the left lung. So this is the photograph of the child after 2 months, in which he is very happy, and the parents are told that before the surgery the child used to keep lying down, didn't play much, but since the surgery had been done, the child keeps on running around, jumping, and in other words, ki kara daddy petrol khatam hi nahi hota. And as can be seen from the chest X-ray also, that the X-ray was completely normal. So coming back to the topic of laryngo tracheo bronchial foreign bodies, God has endowed each human being with 7 orifices, and ENT specialist handles 5 of them, and 3 of them are the ones which can lead to a laryngo tracheo bronchial foreign bodies. Of course, the patients most commonly involved are the children, age group being 1 to 3 years, because of the curiosity of their children and their tendency to experiment with these orifices, and to try to put, if we put a moti inside the ear, what happens, or if we put a eraser inside the nose, what happens, and all these cases can present as just a minor irritation or a life-threatening problem. But before we go forward, just a bit look at the applied anatomy. The most common area where the foreign body lodges is usually the right bronchus. The reasons being that the diameter of the right main bronchus is larger than the left. The angle of divergence from the tracheal axis is smaller on the right. Airflow through the right lung is greater than through the left, and the carina is more likely to be located to the left of the midline rather than to the right. So this all ensures that most commonly the right bronchus is the one which is involved. It is easier to take out a foreign body because of all these reasons, also from the right side. However, when the left get involved, these same reasons are the ones which ensure the task of the ENT specialist is much more difficult than it would have been on the right side. Also, the pediatric airway supporting framework is cartilaginous and soft, pliable and prone to collapse, ensuring that not only the feedback to the surgeon while operating is less, also whenever there is even minimal collapse, it further gets aggravated to the negative pressure created because of the cartilaginous frame. Also, pediatric airway are very prone to develop subglottic edema, not only because supraglottis is surrounded by loose connective tissue prone to edema, but also inflammation from the epiglottis can spread quickly to the pre-epiglottic and paraglottic spaces. This formula is well known to all mathematicians and geometrists, that area of a circle is directly proportional to the radius, and therefore even a minimal decrease in the radius in the form of edema or instrument which is put in by the ENT specialist ensures that the area falls much more than can be expected, as can be seen from this diagram alone. Just a change from 3 to 2 centimeter will decrease the area from 9 pi to 4 pi. So coming to the etiology of laryngo tracheo bronchial foreign bodies, age I have already discussed before. 1 to 3 years is the one which is most common, and male children are of course has hereditary or tendency to experiment more than their female counterparts, and so a ratio of 2:1 is there. In adults, the predisposing factors include interference with deglutition reflex, as in cases of anesthesia with a tooth which gets aspirated, or unconscious patient, for example, stroke. Also, pharyngeal and laryngeal paralysis, like vocal cord paralysis, the chances are higher because that natural protection to the airway is lost. In our present day lifestyle, where everybody wants to run with the breakfast in their hand, improper mastication with hurried swallowing can also lead to foreign body. The types of foreign body we all remember from our MBBS textbooks can be divided into inert and non-inert. The inert ones including the fish bone, chicken bone, and metallic foreign body, spring, nail, etc. In fact, even the button batteries are inert. This has been wrongly written. But button batteries are much more dangerous because the alkaline fluid might seep out and damage the surrounding tissues and lead to pneumothorax. Therefore, they should be removed on emergency basis. Well, non-inert ones are the vegetative foreign bodies like peanuts, chana, which was in our case. And the problem with non-inert ones is that there can be swelling and edema of the surrounding tissues due to the reaction, and therefore they get impacted and create much more symptoms and much earlier symptoms than the inert counterparts. Also, the region can lead to some effect. For example, here in India, in the northeast and West Bengal region, the fish eating is much more common, as well as in the coastal areas. So the fish-borne cases in these areas will be much higher in number. While in North India, the tendency of eating peanuts during winters is very high, and so the number of cases eating these during this time is much more. While in the south, in Hyderabad, there is a tendency of practice of using live fishes to inside the airway to treat asthma patient. For whatever benefit they might or might not be worth, local hospitals have reported with cases of foreign body inside the airway. So coming to the presentation, the typical history is that a child is playing with some small object and suddenly gets a choking episode, and parents to their alarm find that small object is missing. It may be followed by a sudden coughing, or in case the foreign body reaches the vocal cord or is around that area, there might be breathlessness, stridor, hoarseness, or aphonia. If it crosses the vocal cord and is a small foreign body with a low density, it might keep moving up and down along with inspiration and expiration between the vocal cords and the carina, and may present as an audible slap or a palpatory thud. While if it goes into the bronchus, it presents as a asthmatoid wheeze. If at any location it completely blocks the airway, it can lead to sudden death. 20% of the cases present with all this choking episode or sudden coughing for 5 to 10 minutes, and then they are completely symptom free for next 3 or 4 months, when they again start having symptoms like recurrent coughing or hemoptysis or and decreased growth, and then they present. So in our case, it might be that foreign body was there not only for 4 months, maybe for 7 or 8 months, and has presented with the symptoms after some time. Coming to a pathogenesis of a foreign body in the bronchus, a valve mechanism is the best one to explain it. The stop valve mechanism being that air can neither go in or nor go out of the lung, and slowly the air gets absorbed, and therefore there will be hypoinflated lung in a long term. Whereas in bypass valve, air can both go in and out. These cases present with the wheeze. In one-way valve, air can maybe just go inside the lung, which leads to a hyperinflated lung, as in our case, or air can just come out of the lung and not go inside, which presents as a hypoinflated lung. So the clinical features vary depending upon this pathogenesis of bronchial. Whenever such a patient arrives in the casualty or emergency, a quick history along with ABC being the basic principles, a quick history regarding what was the type of foreign body, how long had it been there inside, and if parents are aware of 1 or 2 or 3 foreign bodies, and a quick physical examination which should include all the vital parameters accompanied with SpO2 monitoring. Arterial blood gas analysis would of course be superior, but it might not be present except in the ICU settings. So SPO monitoring has to be there, which gives us an idea regarding the emergency of the situation, and oxygen from a concentrator or DIAC cylinder might be required, and even in some cases cricothyrotomy or tracheostomy might be required. But once the patient is, the further examination begins in the form of indirect laryngoscopy, which gives us an idea up to the level of vocal cords. However, in children it might be very difficult to do it. Second most important investigation being the fiber optic laryngoscopy, which can be passed up to the level of vocal cords and so gives an exact idea of the type of foreign body, its location. For example, a fish which is lodged in the base of tongue, and even up to some extent a trachea can be seen through a fiber optic laryngoscope. If it is beyond the vocal cords, of course a rigid or a fiber optic bronchoscopy has to be done. While fiber optic can be done under LA, rigid has to be done under GA, and at the same instance the foreign body can be attempted to be removed. Coming to the radiology in foreign body, plain chest X-ray has a sensitivity of up to 66% and specificity of up to 51%. However, both AP and lateral views are required to know the exact location of the foreign body. In radiolucent foreign body, it may still be useful due to the features of obstructive emphysema, as was the case in our patient. A study mentioned in Paediatric Pulmonology 2004 mentions that the radiopaque foreign bodies are present in 23.3% of cases. Hyperinflation is seen in 21.8% of cases, while shift of mediastinal shadow is seen in 11% of cases. So our case was among these 11%. Just to give an example of a radiopaque foreign body, a spring is lodged in the right main bronchus and so can be seen in both AP and lateral views. HRCT and CT chest now form the backbone to locate the exact location of the foreign body, not only because of the CT scan but also because they can provide a 2D or 3D reconstruction as well as virtual bronchoscopy. As can be seen from this case, although this is not a foreign body case but a stricture case, how clearly the level of obstruction is shown on a 2D reconstruction of a CT scan. Well, this is a virtual imaging or virtual bronchoscopy. Here the carina is seen distally and tracheal rings more proximal of the trachea. With this we can do virtual bronchoscopy not only up to the level of the foreign body but also beyond the foreign body to see how the airway is beyond it. Especially is important in long standing. MRI though doesn't have much role but might be important in cases of radiolucent foreign bodies and in cases with long standing lesions to see if any bronchiectasis or surrounding lesions have set in. Complications of a case of Laryngo Tracheo Bronchial foreign body can include respiratory distress, asphyxia, cardiac arrest, fever, laryngeal edema and pneumothorax. In long-standing cases, there might be hemoptysis, pneumonia, bronchiectasis, bronchial stricture, or surgical empathy. Coming to the emergency management, in children less than 1 year of age, the ideal way suggested in Scott Brown's is to give back blows by turning the child over the thigh and patting over the back, or other alternative is to keep the child over the thigh as shown in this photograph and give abdominal thrusts. For smaller child, back blows by keeping over the knees can be used, while in adults Heimlich maneuver is the one which is most common and everybody is aware about it. For teenagers they can be put on the chair. For adults it is done as shown in the photograph. The helper stands behind the patient, grasps the abdomen with clasping the hands and gives sudden jerks 4 or 5 to ensure that the foreign body is thrown out from the airway due to the positive air pressure which is created. Perhaps this is what the prince should have done with the princess to remove that apple in her throat. Finger sweeping is no longer recommended and should not be done as it might push the foreign body further into the larynx, while tracheostomy might be required in emergency. Coming to the endoscopic removal, the options are fiber optic as well as rigid bronchoscopy. However, fiber optic is much more difficult to do and remove the foreign body because of the loss of orientation once it is inside. When the fiber optic is placed in, it is touching at various points throughout the airway, and whenever we attempt to move it further inside, each place exerts a pressure in different direction, and therefore the orientation loss is very high, whereas it is much more easier to remove using a rigid bronchoscope. However, without an endoscope, rigid bronchoscope again becomes very difficult, but the newer technology of optical grabbing forceps, it has become easier to remove the foreign bodies using a rigid bronchoscope. The position used is the sniff position to ensure that the tracheal, pharyngeal and oral axis all are in the same line. The problems encountered in endoscopic removal include distorted anatomy at depths, as is seen in our video. There might be fogging, bleeding, edema, or once you go into deeper into the branches, you might not understand which is the branch which you need to take. So you have to study clearly the X-rays and the CT scans to know the lie and the diameter, and approach carefully so that there is no or minimal bleeding, because once the bleeding starts, you cannot cautery in that area. You cannot do good suctioning in the area. The only option remains is to put some adrenaline solution, but which will of course further hamper your vision. So the forceps are used to create the space around the foreign body and remove it. Inorganic foreign bodies usually have a trailing, for example of metal ball. Once you try to grab it, it might further get pushed inside. You have to be careful at the glottis and tongue, as it can strip the foreign body. A good bronchial toilet is required after the foreign body is removed, but every time a bronchial lavage is done, it will decrease the SpO2 for next 2 or 3 days, so oxygenation will have to be done. Other methods of removal of foreign body as mentioned in various researches and articles include use of a Fogarty catheter, which is passed through the foreign body, for example a moti, and then the balloon is inflated and the foreign body. Here a urethral stone basket is used. This photograph shows a bulb at the carina. Urethral basket is used to capture the bulb and remove the foreign body. In places where ventilating bronchoscopes are not available, an alternative suggested is use of laryngeal mask airway with fiber optic bronchoscope, and as shown in the diagram, the bronchoscope is passed through the airway once it is placed to remove the foreign body. The newest thing of course being the optical grabbing forceps, which have made things much more easy to remove smaller and multiple foreign bodies, giving a very good vision once they are inside. Post-op care includes good oxygenation and to watch for SpO2 fall. Steroids and nebulized ethylene are required because there has been manipulation of the airway, and chest physiotherapy in cases of any foreign body particles left over are there or lavage was done has to be done. Coming to the end of the presentation, to summarize, foreign bodies in Laryngo Tracheo Bronchial are most common among children, and they can be potentially life-threatening. Immediate maneuvers like Heimlich maneuver can be helpful to some extent, however the foreign body should be removed early to prevent any edema. Endoscopes as well as imaging are useful in diagnosing the foreign bodies, but endoscopes in removing the foreign bodies require skilled effort and therefore a good amount of training on the part of the surgeon. Post-op care forms as essential a part of management of these cases as is the removal of the foreign body. These are the references which were used, Scott Bone of course being the Bible of the ENT along with Cummings, and the other articles which were used.